Every single day in hospitals across America, surgeons are performing operations on seniors over 70 that the research clearly shows do more harm than good. Surgeries that carry mortality rates of 20-30. And here is the part that should make your blood run cold. Many of these surgeries are being recommended and consented to without the patient being told the real numbers. Today, I'm going to tell you the 5 surgeries seniors should seriously consider refusing. Many of these surgeries are being recommended and consented to without the patient being told the real numbers. Hi, I'm Dr. Marty Makery, and I want to start this video with something very important. I am not anti-surgery. Surgery has saved countless lives, including people I have personally treated. Modern surgery is one of the great achievements of medical science. But I am absolutely, unequivocally opposed to surgery being recommended, performed, or consented to when the evidence does not support it. And in the United States, with its fee-for-service medical system, where surgeons get paid to operate, and hospitals generate enormous revenue from surgical procedures, there is a financial incentive structure that does not always align with the best interests of the patient, particularly the senior patient. Here is the reality of surgery in older adults that most surgeons do not discuss openly enough. The aging body responds to the physiological stress of surgery in fundamentally different ways than a younger body. Anesthesia affects the aging brain differently, and far more dangerously. Recovery from surgical trauma is slower. Immune response is diminished. Wound healing is impaired. Cardiovascular stress from surgery is greater. The result is a concept in geriatric medicine called post-operative mortality and morbidity in older adults, and the numbers are sobering. For adults over 80, major elective surgery carries mortality rates that would be considered completely unacceptable in younger patients. Yet these operations happen every day. There is also something called post-operative cognitive dysfunction, POCD, which is essentially surgery-induced cognitive decline. Emerging into surgery with a sharp mind and coming out months later with memory problems, personality changes, and reduced cognitive capacity. This happens to a meaningful percentage of seniors who undergo major surgery, and it is almost never disclosed adequately before consent. Now, to be absolutely clear, I am not telling you to refuse all surgery. Some surgeries for seniors are life-saving and absolutely essential. The 5 I am going to cover today are specifically the ones where the evidence of harm in older adults is strongest, where alternatives exist, where informed patients consistently make different choices when given the full picture. This is about informed consent. Real informed consent, not the document you signed 10 minutes before going under, but a genuine, complete understanding. A genuine, complete understanding of what surgery does to your body, what the real outcomes data shows, and what alternatives your surgeon may not have mentioned. Let's start with surgery number 1. Surgery number 1, open heart coronary artery bypass grafting, KBG, in adults over 80. And I want to be precise here. I am specifically addressing the elective or semi-elective version of this surgery in the very elderly. The procedure involves stopping the heart, using a heart-lung bypass machine to maintain circulation. Coronary artery bypass surgery is one of the most common major surgeries performed in the United States. The procedure involves stopping the heart, using a heart-lung bypass machine to maintain circulation, and using harvested blood vessels, typically from the leg, to route blood around blocked coronary arteries. In adults under 65, the outcomes data for bypass surgery is generally favorable when properly indicated. But when we look at adults over 80, the picture changes dramatically. Studies published in the Annals of Thoracic Surgery show that operative mortality for CABG in patients over 80 ranges from 8 to 15%, and in some high-risk populations, significantly higher. That means for every 100 adults over 80 who have this surgery, between 8 and 15 of them will not leave the hospital alive. This compares to a mortality rate of under 2% in younger, healthier adults. The heart-lung bypass machine required for open heart surgery can release small emboli, microscopic clots, and debris. Microscopic clots and debris into the bloodstream that travel to the brain. Stroke risk is significant. Stroke rates following CABG in adults over 80 are significantly elevated, 5 to 10% in some studies. For an 80-year-old who may already have some degree of cerebrovascular fragility, a surgical stroke is often devastating. Up to 40 to 50% of seniors who undergo cardiac surgery show measurable cognitive decline in the months following. Many improve partially over time. Many do not return to baseline. Families say the person is not the same. Up to 40 to 50% of seniors who undergo cardiac surgery show measurable cognitive decline in the months following, can achieve comparable blood flow restoration without opening the chest without stopping the heart. Additionally, optimal medical therapy, aggressive medication management, has been shown to produce comparable outcomes, producing outcomes comparable to bypass surgery in many stable patients at a fraction of the risk. If recommended for bypass and over 75, demand a second opinion from a different institution. Ask specifically about PCI or medical therapy. Ask specifically, am I a candidate for PCI or optimal medical therapy instead? What are my actual risks? A surgeon who pushes back on these questions or dismisses them is a surgeon you should be concerned about. Surgery number 2, and this one is performed at an extraordinary rate in the US, spinal fusion surgery for back and neck pain. Spinal fusion involves connecting vertebrae with metal screws and rods, permanently eliminating natural motion. It is a major surgery, permanently eliminating the natural motion between those vertebrae. It is a major surgery, requiring general anesthesia, significant blood loss, and a prolonged, painful recovery. And in the United States, it is performed at a rate that is 2 to 3 times higher than in any other developed country. That disparity is not explained by Americans having worse spines. It is explained by financial incentives. Multiple high-quality randomized controlled trials have found that spinal fusion produces outcomes no better than conservative treatment for many patients. The SPORT trials published in JAMA found that surgical outcomes were not meaningfully superior over a 2 to 4 year period. In adults over 70, spinal fusion carries specific risks that are amplified by age. Hardware failure is a significant complication, where the vertebrae above and below the fusion deteriorate faster because of the unnatural mechanical stress. Where the vertebrae above and below the fusion deteriorate faster because of the unnatural mechanical stress. And the anesthesia exposure for what can be a 4 to 8 hour surgery in an 80-year-old is profoundly significant. A study found that seniors over 65 had a readmission rate of nearly 15% and a complication rate over 20%. Epidural steroid injections can provide significant pain relief. Radiofrequency ablation has excellent evidence too. What actually works? Targeted physical therapy led by a trained therapist produces outcomes comparable to fusion for many. Weight management and aquatic therapy are particularly effective because they allow mobilization without joint loading. Ask, before we discuss surgery, what is the complete non-surgical treatment plan? How long has it been tried? If you haven't had 6 to 12 weeks of dedicated physical therapy, you are not ready for fusion surgery. Surgery number 3, and I want to approach this with tremendous care, aggressive cancer surgery in very elderly patients. I am not saying seniors with cancer should not receive treatment. Treatment can absolutely be appropriate. What I am addressing is high morbidity cancer surgeries without adequate, honest discussion of life expectancy. The Whipple procedure for pancreatic cancer involves removing parts of the pancreas and intestine. It's extremely complex. It involves removing the head of the pancreas, part of the small intestine, and the gallbladder. In community hospitals, operative mortality for the Whipple can reach 10% or higher. For patients over 80, it's more. A very elderly patient may spend 9 months of their remaining life recovering from a catastrophic surgery and never achieve quality of life, and never achieve a quality of life equivalent to what high-quality palliative treatment would have provided. Prostate cancer surgery is one of the most overperformed. Most cases over 75 are what oncologists call indolent. They will never cause symptom or death within the lifespan. The man will die with prostate cancer, not from it. Active surveillance monitoring the cancer with regular PSA tests has been shown to produce equivalent survival outcomes. Active surveillance monitoring the cancer with regular PSA tests has been shown to produce equivalent survival outcomes. Colorectal cancer surgery in frail elderly patients over 85 carries mortality rates that can exceed 20%. An honest conversation about benefit versus palliative care is essential and often never happens. Number 1, get a second oncology opinion. Number 2, ask specifically about survival benefit versus non-surgical care. Number 3, ask for a palliative care consultation early. Palliative care is not giving up. It is optimizing quality of life. Surgery number 4, carotid endarterectomy, CEA. In high-risk elderly patients, it removes plaque to reduce stroke risk. In certain populations, the benefit is real, but it's being extended far beyond that proven group. To seniors with surgical risks that may exceed the stroke risk the surgery is meant to prevent. The surgery carries a 2 to 5% risk of causing a stroke during the procedure, the outcome it is meant to prevent. In older patients with more fragile arterial walls, the likelihood it will cause a stroke may be greater than not operating. The CREST trial found that in patients over 75, stenting was associated with a higher stroke rate. Optimal medical therapy, high-intensity statins, blood pressure control, is now producing achieved results not possible 20 years ago. Ask, am I symptomatic? Have I had a TIA? What is my surgical stroke risk specifically? Ask, am I symptomatic? Have I had a TIA? What is my surgical stroke risk specifically? Surgery number 5, and I want to be extremely precise here. Aggressive joint replacement in severely frail seniors. Joint replacement, done in the right patient, is one of the most genuinely successful surgeries in modern medicine. What I am addressing is joint replacement in severely frail elderly patients over 85 with multiple serious conditions. Frailty is a medical concept, a measurable state of physiological vulnerability. Frail seniors have impaired ability to respond. Impaired ability to respond to the stress of surgery, anesthesia, hospitalization, and rehabilitation. Studies have shown that severely frail patients have dramatically higher rates of postoperative complications, including pneumonia, deep vein thrombosis, wound infection, and delirium. Readmission rates are significantly elevated. Postoperative delirium affects up to 50% of elderly patients after major surgery. It can trigger a cascade of complications and permanent decline. Delirium can trigger aspiration, falls, medication errors, and permanent cognitive decline or institutional placement. Crucially, many never regain the functional capacity or independence they had before surgery. It begins a permanent decline. Questions: has the patient had a formal frailty assessment? What is the realistic functional goal? In a severely frail 87-year-old, these non-surgical options may represent a far better risk-benefit equation than surgery. Ask the hard questions first. In a severely frail 87-year-old, these may represent a far better risk-benefit equation than surgery. I want to talk about something that cuts across every surgery on this list, almost never discussed: general anesthesia in seniors. General anesthesia is a profound neurological intervention. It is not simply being put to sleep. It involves flooding the brain with powerful sedative, analgesic, and paralytic agents that suppress consciousness. Research has shown measurable cognitive decline in 10 to 40% of patients over 65. POCD is real. Patients describe it as, "He wasn't the same after. She forgot things she always knew. Personality changes happen." Ask specifically about POCD risk. Ask whether regional anesthesia, spinal or epidural, is an option. Ask about a preoperative cognitive baseline assessment so that any change can be objectively measured. I want to leave you with 7 concrete, actionable rules. These are the rules I would give my own parents. Write these down. Rule 1. Never consent to elective surgery in a surgeon's office on the day of recommendation. You have time. Any surgeon who pressures you to decide immediately for a non-emergency procedure is a surgeon whose judgment should concern you. Rule 2. Always get a second surgical opinion from a different hospital, not a colleague of your surgeon. Medicare covers second opinions. Studies show they change the recommended treatment plan in 20 to 30% of cases. Ask, what is your complication rate for this procedure? If they won't answer, that is an answer in itself. Ask, what is your complication rate for this procedure in patients my age? If they won't answer, that is an answer. Rule 4. Ask whether you have been assessed for frailty. Scale tools predict outcomes far better than age alone. Rule 5. Demand a full non-surgical alternative discussion. Make your surgeon explain every option evidence-based. Rule 6. Request a geriatric consultation for major surgery. Geriatric programs optimize your pre-surgical condition. Chang. Discuss regional versus general anesthesia. Make sure they know your concerns before you ever enter that room. Ask about delirium prevention protocols. Make sure your anesthesiologist knows your concerns before you enter that room. Let me bring this all together. The 5 surgeries we covered today are not bad surgeries in themselves. They are surgeries that carry risks in elderly patients that are often not communicated fully, honestly, and compassionately. You deserve the full picture. You deserve a surgeon who looks you in the eye and tells the real numbers. Your life is not a revenue line. Your body is not a surgical case number. You are a human being. Share this video with every senior you love. This video might stop a catastrophic surgery from happening. You deserve medical decisions that honor your age, your values, and your right to know the truth. Hit the like button and subscribe for Health Truth every week. Drop a comment and tell me what happened to you. I'm Dr. Marty Macari. Advocate for yourself, ask hard questions, and I will see you in the next video. Stay empowered. Truth matters. Take care.